Chronic bronchitis. Chronic bronchitis is defined clinically, not by imaging or pathology, but purely by history. It is a productive cough with sputum, occurring on most days, for at least 3 months in each of 2 consecutive years, once other causes of chronic cough have been excluded. It's the second major form of COPD, alongside emphysema. Together they make up the 2 overlapping components of COPD. This is one of the few major respiratory diagnoses defined purely by a time-based clinical criterion, rather than a pathology or imaging finding. It is worth explicitly pointing this out, since it's a common exam trap. What investigation confirms chronic bronchitis? Answer is none. It's a clinical diagnosis by history. So, what's actually happening in the airways? Chronic irritation, most often from smoking, causes ongoing inflammation of the lining of the bronchi, the larger airways. The mucus-producing glands in the airway walls become enlarged, hypertrophied, and the number of mucus-producing goblet cells increases. This results in that the airways produce far more mucus than normal, and become chronically inflamed and narrowed. We can use Reid Index to diagnose chronic bronchitis. The key pathological measurement historically used here is the Reid Index. It is the ratio of mucus gland thickness to the total thickness of the bronchial wall. An increased Reid Index, which is normally under about 0.4, is the pathological correlate of chronic bronchitis. Though in practice this is a research autopsy finding, rather than something checked routinely in living patients. Why does chronic bronchitis happen? It has following major causes. Cigarette smoking is the overwhelming major cause, just like emphysema. Air pollution, occupational dust and chemical fume exposure. Recurrent respiratory infections. Biomass fuel smoke exposure, relevant regionally as indoor cooking smoke. Chronic bronchitis and emphysema share the same major risk factor, that is, smoking, and often coexist in the same patient. This is exactly why COPD is usually described as a spectrum with overlapping features, rather than pure emphysema or pure chronic bronchitis in most real patients. The core mechanical difference from emphysema is worth stating explicitly. In emphysema, the problem is loss of elastic recoil and airway collapse from destroyed alveolar walls. In chronic bronchitis, the problem is airway lumen narrowing from inflammation and mucus, with the alveoli themselves relatively preserved. Both processes cause obstruction, but by genuinely different mechanisms, which is why they're taught as distinct entities despite both falling under COPD. Here is a quick recap. Chronic bronchitis is a productive cough most days, for 3 or more months, for 2 or more consecutive years. It is a clinical diagnosis, not a pathology or imaging one. Its mechanism is airway inflammation and mucus gland hypertrophy, leading to excess mucus, resulting in airway narrowing. Its main cause is smoking. Its classic picture is blue bloater. Together with emphysema, it makes up COPD.